Okay, in section 2, we're going to be looking at neurological management. We'll be talking about altered mental status, different types of seizures, um, stroke. So basically, quick review: the body or the brain is the body's computer. It controls our breathing, speech, and all other body functions. All thoughts, memories, needs, and desires take up residence in the brain. It's divided into three major parts. You have the brainstem, which takes care of basic functions, breathing, blood pressure, swallowing, pupil constriction. You have the cerebellum, which is control of muscle and body coordination. And then you have the cerebrum, which is the largest part, and it contains a right and left hemisphere, um, a back part, uh, helps with sight, the front, emotion and thought, the middle part, sensation and movement. The left hemisphere is one we use for speech. Altered mental status. This is going to be a change in a person's level of awareness, and there's many causes. Uh, there's an acronym we like to use for assessment, AEIOU TIPS. This kind of helps us remember some of those causes or most common causes of altered mental status. That's going to include alcohol, epilepsy, insulin, oxygen, uremia, trauma, infection, psychiatric, poisoning, shock, and stroke. There are several types of seizures. You can have generalized, which would include like a tonic-clonic type seizure, or an absent seizure. You can have partial, which can be either simple or complex, and you can have status epilepticus. So with tonic seizure, muscles will stiffen and the patient loses consciousness. Muscles contract and the back will arch. Chest muscles tighten and breathing becomes more difficult. Cyanosis of the lips and face may also be seen. Clonic seizures, this is where the muscles spasm and jerk. Muscles will flex and relax rapidly. So the tonic clonic together sometimes are what used to be called grand mal seizures. Um, this is where the tonic and clonic type seizures occur together at the same time. It's rare to experience one without the other. So a lot of times, if you have uh, clonic type movements, you also will have some tonic movements in there as well. Absent seizures used to be called petit mals. They're fairly uncommon, but they do happen. They occur suddenly without warning. The patient may appear to stare without moving. Usually lasts less than 15 seconds. Normally, there is no postictal period with this, compared to the grand mal seizures. Um, I've seen patients uh, be in the middle of a conversation. They'll space out for a few seconds, 10, 15 seconds. And then when they come to, they pick up the conversation right where they left off, had no recollection that they weren't there for those few seconds. So you start seeing things like that. Uh, you might consider absent or petit mal seizures. A simple partial seizure is one that is localized to one area of the brain. There is no loss of consciousness with this. Um, they're usually broken into 4 different categories. You can have motor, sensory, uh, autonomic, or psychic. So with the the motor, you have a simple partial seizure with motor symptoms will affect muscle activity, causing jerking movements of either the foot, face, arm, or another part of the body. It's usually localized and not like global, like what you would see with the tonic-clonic movements. Sensory, with sensory symptoms, it will affect the senses of hearing problems, possible hallucinations, or other distortions. Autonomic affects the part of the brain responsible for involuntary functions. It may cause changes in blood pressure, heart rhythm, or bowel function. And then the psychic, this affects the part of the brain that triggers emotions and previous previous experiences. It may cause feelings of fear, anxiety, feelings of deja vu. Those are be included in that simple partial. Complex partial seizures, they can affect any lobe of the brain. They cause alteration of awareness due to spreading seizure activity. They may also come with an aura, so they're often described as having an aura as a warning that one's getting ready to come on. Patients may stare blankly into space, again, kind of like the absent seizures. They may have non-purposeful or repetitive movements. Status epilepticus is a continuous seizure lasting more than 30 minutes, or 2 or more seizures without regaining consciousness between any of them, or prolonged seizures between 5 and 30 minutes. These seizures between 5 and 30 minutes should be treated as status until proven otherwise. Mortality rate can be around 20%. I have seen patients go into cardiac arrest from status epilepticus, especially if treatment is not initiated quick enough. Highest mortality occurs from anoxic and cerebrovascular causes, so you can have anoxic brain injuries from not getting enough oxygen to the brain. Seizure duration is the greatest predictor of mortality. Status epilepticus lasting greater than 1 hour has significantly higher mortality. Most common in ages greater than 60 or less than 12. There's also a high prevalence in patients with chronic epilepsy. So, in dealing with status epilepticus, remember, time is brain. Status is an emergency and needs to be treated promptly. This can be absolutely a life-threatening event. So physiologic changes that happen during status. Phase 1 is compensation. The body's able to compensate for the first 30 minutes. Cerebral metabolism is increased due to seizure activity. The body is able to meet the increased metabolic demands, and cerebral tissue is protected from hypoxia and metabolic damage. So, with increased brain metabolism, you'll have increased cardiac output, tachycardia, hypercalcemia, massive catecholamine releases, and incontinence. If you have elevated systemic and pulmonary artery pressure, that's going to lead to hypertension. You'll have cardiac dysrhythmias, lactic acidosis, hyperthermia, vomiting. During phase 2, this is where we start to decompensate. This occurs after 60 minutes. And remember, anything greater than 1 hour, your mortality goes up substantially. So after 60 minutes, increased metabolic demands can no longer be met. You have hypoxia, and cardiorespiratory functions may progressively fail to maintain homeostasis. In this failure of cerebral autoregulation, you'll have also respiratory and cardiac impairments. Um, for the autoregulation, you'll have, when it fails, you'll have hypoglycemia, hypotension, hepatic and renal dysfunction, hyperkalemia, it could go either way, falling lactic acid levels, multi organ failure, and leukocytosis. Some of the respiratory and cardiac impairments would include systemic hypoxia, so you're in a state of shock, failing cardiac output, metabolic and respiratory acidosis, coagulopathies, rhabdomyolysis will happen, hyperthermia, and increased ICP. Complications, just to name a few, we could have aspiration, bone and spine fractures from either the initial fall or the tightening of the musculature during the seizure activity. There's a lot of forces being put on the body during that time. Brain damage from lack of oxygen and or depletion of glucose can also cause brain damage. Dehydration, because remember, your metabolic demands go way high, and the body just has a hard time keeping up with all that. Other neurological emergencies, some causes of these would include non-compliance. That's probably one of the biggest things. Rapid increase of body temperature, febrile seizures, infection, hypoxia, traumatic brain injuries, alcohol or drug withdrawal, stroke, hypoglycemia, eclampsia, seizure disorders, electrolyte imbalances, and poisonings. These can all lead to or cause neurological emergencies. Assessment findings. You may see spasms, muscle contractions, shaking, or tremors, like with the seizures. You may see profuse sweating, cyanosis during seizure activity, increased secretions that's from the catecholamine dump, incontinence, postictal states. Management. So, first thing we want to do is protect them from further injury, position them on their side to protect their airway, ensure that they do have an open airway, adequate ventilations, and oxygenation. You might also consider using MPA, providing emotional support, reducing the stimulants that may trigger more seizures. Some of them can be triggered by light or sound. You want to get them out of that environment into a more calm environment. You're going to need IV or IO access, so we'll need a paramedic for this as well. And they'll need to consider administration of benzodiazepines, like Versed, for further seizure activity. So, traumatic brain injuries. These can be either direct or indirect. Primary injury is a direct blow to the brain and associated structures. Indirect is caused by cerebral edema, intracranial hemorrhage, cerebral ischemia, or infection. The two most common causes of hypotension are hypotension and hypoxia. Cushing's reflex. This is a neurological response to increased intracranial pressure. So as the pressure rises, the body tries to compensate and overcome the forces in the cerebral vasculature, right? And it does this by an increase in systolic pressure, a decrease in heart rate, and irregular respirations. So that's Cushing's reflex or Cushing's triad. Other forms of traumatic brain injury We could have an epidural hematoma, subdural hematoma, intracranial or intracerebral bleed, or subarachnoid. Um, so with the epidural hematoma, this happens between the skull and the dura mater, most commonly around the temporal bone. Middle meningeal artery is usually affected, and you'll have an immediate loss of consciousness with a lucid period. That is very, uh, very important to note. Uh, Most commonly, you'll see these patients that's had head trauma of some form or another, like with sports and football and things like that. They'll have an immediate loss of consciousness, then they'll be lucid for a period, and then they'll start to decompensate and have altered mental status again. When you start seeing that, think epidural bleed, or epidural hematoma is forming there. Um, Subdural hematomas, they happen beneath the dura but outside of the brain, and this is usually a slow venous bleed, from disruption of the veins and capillaries. You'll see fluctuating loss of consciousness or slurred speech. And with this can happen hours or days or weeks after the initial injury. Most commonly, we see um, older patients who have gotten altered mental status. Confusion is most common one that has kind of set in over the past couple of days or weeks. Um, and then when we're talking to the family or trying to get a history, we always want to find out, are they on blood thinners, and have they had any recent falls? Because they may not think about the fall that they had last week causing symptoms that we're seeing today. So they may say, yeah, he's on Xarelto, and he did fall last week. And so if we have those things, we need to be thinking he may actually have a slow bleed or a subdural hematoma. Um, Intracerebral, this happens within the brain, penetrating rapid decelerating forces. Um, so it happens within the brain, and it's usually caused by penetrating or rapid deceleration. It can happen at the frontal or temporal, which is the most common. Um, Once symptoms appear, patient deteriorates quickly. So because of those things going on, like with if you got rapid deceleration in an auto accident that has ruptured this, and you start having a bleed, by the time we start seeing symptoms, it may be too late, because they will deteriorate very, very rapidly when we have an intracerebral bleed there. Subarachnoid, this happens in the subarachnoid spaces where CNF circulates. You'll see neck rigidity and headache. So, um, most of these injuries, you'll see a blow to the head with or without symptoms. They may have a history of loss of consciousness, confusion, brief loss of memory, like retrograde amnesia, or antegrade amnesia, which would be anything that happened right after the event. So they have those brief losses of memory, dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, headache, lack of coordination. So, assessment and management of traumatic brain injury or traumatic head injury is going to be, um, first and foremost, hemorrhage control. If they're bleeding, let's stop it, and let's maintain ABCs. And we want, with traumatic brain injuries, we want our end tidal CO2 between 30 and 35. This helps with dilation of those cerebral arteries, and therefore helps with the Cushing's reflex. Um, You want to assess what their baseline level of consciousness is. Reduce on-scene time is critical to survival after determining and correcting life threats. So stabilize, then go. We gotta fix those life threats. Any uncontrolled hemorrhage, we need to control. Any issue with airway and breathing, circulation, we gotta fix that. And once we've fixed life threats, we need to get out of there. We need to determine whether cervical collar is needed to be applied or immobilization is necessary. And with the newer protocols, we're really not using backboards except for extrication and transferring to stretchers. But we're still making sure we are protecting C-spine. Now, that being said, because this is neurological, we may, if there are deficits, it's still okay to go ahead and leave them on the backboard, because we can use that as a long splint to, they may have other injuries along the spinal cord process that we need to protect. So it's okay to go ahead and leave them on that backboard if they're altered and can't tell you, or if they're altered and they have these deficits, these neurological deficits. So we always want to protect that spinal cord from further injury. Like I was saying, current practices for spinal immobilization, mechanism alone is not reason to immobilize. If the patient is fully alert, has no spinal complaints, no neurological deficits, no evidence of mind-altering substances or other illnesses that could distract from or mask symptoms, then they don't need to be immobilized. But if you're ever in doubt, if the mechanism is high enough and you're not sure, you go ahead and err on the side of caution and immobilize them. Okay? Strokes. We can have hemorrhagic and we can have ischemic. Ischemic is going to be the most common. This is caused by a blockage or clot, embolus that has blocked blood flow in the brain. This accounts for 80% of all strokes. You will see neurological deficits on the opposite side of where the blockage is, or the opposite side of the injury. So if the clot is on the right side of the brain, you will see deficits on the left side of the body. Hemorrhagic. This is basically a bleed in the brain tissue itself. Blood vessel, it can be from blood vessel rupture. That's where the epidural hematoma, intracranial hemorrhages, and things like that we talked about earlier. Those are all hemorrhagic forms of stroke. They do account for 13% of all strokes. They are often fatal. They may present with sudden and severe headache. The patient may describe it as being the worst headache I've ever had in my life. They start describing things like that, we need to be a bit concerned, right? So with the transient ischemic attack, TIAs, this is what doctors used to refer to as mini strokes, where no actual death of tissue occurs. They are often a pre-warning that a stroke is imminent, and should be followed up by a physician. Always, 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 always. Just because they had stroke-like symptoms, and then when we get there, those symptoms are gone or nearly gone. These are not patients I'm letting sign a refusal. They're still getting evaluated by at least a physician and usually a neurologist as well. Blood flow to the brain is obstructed with a small clot. These usually resolve in less than 24 hours. Oftentimes it will resolve before we arrive or during transport. Though that is, reassuring to see those things resolve. it still warrants further investigation. It's also important to note signs and symptoms and at the time of onset. We always want to know the last known well with any stroke or TIA type symptoms. We want to know when was their last normal, how long has this been going on, because time is brain. A lot of the interventions that they can do for stroke, ischemic, or hemorrhagic, well, mainly ischemic, dealing with clots, all those different interventions are time dependent. So we really need to establish a very, very good timeline. Signs and symptoms of stroke: facial droop, sudden weakness, numbness, the face, arm, legs, usually unilateral on one side of the body, lack of muscle coordination, blurred or double vision, difficulty swallowing, decreased level of respirations, speech disorder, slurring of speech, unable to get their words out, unable to understand the words you're speaking to them. Basically, anything that shows a cranial nerve deficit. These are all related to functions of the cranial nerves. That kind of tells us if we got a brain in trouble or not, right? Remember the FAST acronym: face, arm, speech, time. Make sure we use it, and make sure we're using our FAST-ED scores so we can determine if we have a large vessel occlusion. That's going to determine where we're taking these patients a lot of times. Aphasia. This is disordered thoughts, either expressive, where they're using wrong words, or it could be receptive, or they're not understanding words. It can be other signs would be severe sudden onset of a headache, confusion, combativeness, tongue deviation, coma. Risk factors. There are many, and especially in our local population, we have a lot of risk factors because we got a lot of elderly. We do have some different ethnicities, high blood pressure, high cholesterol, diabetes, heart disease, obesity, stress, cigarette smoking. These are all things that our local population is very bad for. And so they're always at risk of stroke. Even lack of exercise. We got a lot of people who just don't get enough exercise anymore. Identifying, assessing, and treating the stroke. First and foremost, like I said, we want to identify those signs and symptoms quickly, do a quick stroke scale, Cincinnati, or whatever. Make sure we find out as early as possible and find out what the patient's last known normal was, manage our ABCs, life threats. Cincinnati stroke scale is what we usually use around here. Call for ALS backup. Don't wait on scene. Always meet them en route. And there's a lot of misconception around ALS backup. You don't have to have a paramedic to call for a flight. That flight is your ALS backup. There's two patients that I will fly more times than not, and that's going to be a stroke patient every time, and a heart attack most of the time, depending on how close I am to the nearest cardiac center. But a stroke, I will fly every time if I can. So don't wait on scene. Go ahead and call for ALS. Get you a helicopter. Get you a paramedic en route. You want to position the patient for transport. We're going to be setting them up, not laying them flat. Transport to the most appropriate facility, not necessarily the closest facility. Notify the receiving facility that you do have a stroke patient. Let them know as soon as possible, once you figure out where you're going, that they got a stroke coming so they can activate stroke alert. So in summary, you want to make sure that You remember the many reasons for altered mental status using AEIOU tips, uh, and be able to recognize quickly and transport appropriately the stroke victim. And that's going to be the end of Module 1, Section 3. Or, excuse me, Section 2. Next will be Module 1, Section 3.